Hi guys, my name is Shira Cohen, and I would like to share with you the presentation that I have. It's a PowerPoint that it includes pretty much everything you must know to pass the AANP. I am a nurse educator. I have my master's in nurse education, so I love to teach. This is why I'm doing this. And I recently passed my AANP, and I need to let you know that the exam is not tricky. It's not like the NCLEX. The NCLEX would have two answers that are very attractive. They're probably both correct, but there's always one that's better. With the AANP, you will find that one answer makes absolute sense and the others don't belong to the question. I hope that relieves a little bit of your anxiety. I later on will talk about test taking skills that you should do and practice while taking the exam. And I don't want to bore you out, but I want to start the presentation. I'm going to start a timer because I don't want to go over 30 minutes because I want to divide the recordings so that you don't get too bored, because after a while you just don't pay attention anymore. So this is the presentation, and I'm going to go ahead and just start throwing information at you, and I hope these things come into your head and you're like, yep, I know it, I knew it, I knew it, I knew it. So let's talk ortho. Let me move my screen here so that I'm not covering material. So let's talk osteoarthritis and rheumatoid arthritis. So osteoarthritis, let's talk about what is happening. With osteoarthritis, you have the bones that are literally touching each other. Usually you want some space in between so it doesn't hurt, it's nice and soft. But with osteoarthritis, both bones are touching each other, there's a lot of pain. With rheumatoid arthritis, you should be thinking that I personally think that it's just worse than OA, in the sense that it's angry, red, swollen, painful, inflammation, big joints. And that's what's happening with RA. You should know that RA is symmetrical and osteoarthritis not necessarily. And let's talk about these nodes, because with osteoarthritis, you should know for testing purposes that the patient can present with Heberden's nodes and Bouchard nodes. And I apologize in advance for pronunciation, but the test doesn't quiz you on that, so nobody cares. Osteoarthritis, the patient will present with both Heberden's nodes and Bouchard. The patient will present with PIP and DIP, right? PIP for proximal, DIP for distal. RA is different. The patient will present with only the Bouchard, the proximal nodes. You must master that concept. Let me just, since we're talking about joints and bones here, let's talk about patient education for Fosamax. Fosamax. What is Fosamax? Alendronate. It is a biphosphonate. You give biphosphonates to patients who have thin bones. Thin meaning that they're losing the density, the substance to them. All right. So you would give these to people who have osteoporosis. And there's specific patient education things that you should tell your patients who are taking Fosamax. Now, Fosamax, picture it as a ginormous pill, a huge pill. So tell patients to drink it with plenty of water. You want that pill to go all the way down to the stomach. You don't want it to stop halfway in the esophagus, because if it does, it can cause erosion into the esophagus. So a lot of water to push it all the way down. You tell them to take it first thing in the morning with no food, no other drugs. Take it alone because it can interact with a bunch of things, and tell them to stay upright. If they lay down, the pill may make its way up back into the esophagus and cause that erosion. So you tell them to stay up and seated. So a patient should never take this in the evening before they go to sleep, and make sure the pill goes down. Let me jump back into OA and RA. You should know that with one of these, there's morning stiffness that usually lasts less than 60 minutes. And I hope you're thinking osteoarthritis, because with rheumatoid arthritis, the stiffness goes on over an hour. These, again, RA is just the worst case than OA. I like to think it in my head for testing purposes. So it takes them longer to loosen up the joints. That stiffness is just lingering. So know that difference. Let's talk about the DEXA exam that you can order for your patients so you can diagnose between osteoporosis and osteopenia. Now, what's the difference between the two? Osteopenia, osteobone penia, small amount, small amount. It's bones that are starting to lose their density. Not horrible, not osteoporosis horrible, but they're making their way there. And then you have osteoporosis, which is, think of it like Swiss cheese bones. There's literally holes, there's pores, porosis, pores in the bone. So it's a worse case than osteopenia. So the results will come and say, for example, this patient's results were negative 2.5, or heck, whatever, even more than that. You should automatically think osteoporosis. Negative 2.5 in the DEXA exam is osteoporosis. If the patient's results come back at 1.5, which is less than, and I'm talking negative numbers, it's less than 2.5, then it's osteopenia. So just know that. And since we're talking about bones, and there's one specific thing you should know about hypertensive medication in people who have osteopenia, say the test asks you, a woman who comes in with osteopenia and hypertension, what classification of drugs would you want to order for this patient? You should think, for hypertensive medication, you should think thiazides. You give thiazides to the women, the patient that has the osteopenia. Why does it work? I'm not sure. It just does, and you should know it. Let's move to the shoulder. Shoulder impingement syndrome. Impingement, there's something that it's causing pain in the shoulder. Patient tells you they can't reach for the can of beans anymore and do this motion because it hurts them. They can't lift the arm past 90 or somewhere up here. You can even perform the painful arc test. The painful arc, you tell them to move the arm all the way up to the top. It's an arc, right? Because it's this arc. And if they stop right here and they tell you, oh my God, it hurts so much, I can't raise it higher than that, you think impingement syndrome. Now, the difference between impingement syndrome and rotator cuff issues is that with the rotator cuff in the question, if it says something about numbness, you should think rotator cuff, not impingement syndrome. So just know that. Adhesive capsulitis. What the hell is adhesive capsulitis? Think of what the words are saying. Adhesive is like glue, like adhesion, glue, together, clump. Capsulitis, in the capsule, causing inflammation. Things are glued together. This is frozen shoulder. So just remember that. If you see adhesive capsulitis or frozen shoulder, you know what we're talking about. And who is at risk of developing frozen shoulder? Unless you read this somewhere or somebody told you, there was no way for me knowing this, but I learned it, and it's diabetes. Diabetic patients are at highest risk of getting adhesive capsulitis. And if you need a way to remember, because this is how I study and how I remember things, think of the diabetic patient has sugar in their bloodstream that causes adhesive of together, and just think of a shoulder getting adhesive from the sugar getting stuck, glued, I don't know. That it helped me, I hope it helps you. Extrinsic shoulder pain. That means pretty much that the patient comes in, oh my God, my shoulder hurts, but you can't just assess the shoulder. You have to assess the surrounding features, because it may be something wrong with the neck that it's presenting in the shoulder. So intrinsic pain means that the pain is caused by something else. So patient comes in, they're saying their shoulder hurts. Check the neck, check everything. Have them move the head side to side, up and down, because of the problem. It's with the neck, it may present in the shoulder. So just know that. I hope you already know and have mastered the difference between elbows, tennis elbow, and the golfers, right? And the way I remember is that when you play golf, it's the median aspect that it's getting most of the stress when you're using golf. when your elbow, tennis elbow, I think of Serena Williams doing one of these. Bah! It is the lateral aspect that it's getting hit. So golf, medial aspect, lateral for tennis. And I hope you remember that. Scaphoid fracture. A scaphoid fracture happens usually when the question will say something like, the patient fell, landed on their hands on the floor, and after a day or a couple of days, they start developing really bad pain right here at the snuff box area. Snuff box tenderness, right here. You can almost see my box. Right there. So what do? You send them for an x-ray, but guess what? The x-ray comes back and it's negative. That doesn't mean that you can completely rule out scaphoid fracture. What you should know is that the first x-ray may not show the fracture. If the patient were to come back a week or two later and you do that x-ray again, it'll probably show in the second week or third week. So you can't rule it out completely. And if you as a provider must know right away if it's scaphoid and the x-ray didn't show it, go ahead and order an MRI. That's right. We've been taught all over that we shouldn't order expensive tests. But this is a case where you have a pretty good idea because of where the pain is located, what happened with the story that they fell, and the x-ray, which is inexpensive, came back negative. It would be okay to order like an MRI or a CT, okay? Sciatica. The question will either ask you what's the best test for that, and I hope you're thinking the patient is laying down and you lift the legs and it causes shooting pain to the back of the leg and the glutes, then sciatica. And the other thing that you should know, or the question may say that the patient is complaining of pain that radiates from the back to the bottom of the leg past beyond the knee level. Know that, sciatica, okay? Let's talk a little bit about ankle sprain. Let me check my time because I don't want to bore you. Very good, we have 19 minutes. Ankle sprain. Which sprain will come to your office? Not the grade 1. This is the sprain where you twist your ankle, you felt pain, it goes away in a couple of days, and the patient can handle it at home on their own. Grade 3 won't come to you. They'll go to the emergency room. These are the people whose ankles swell up to the size of a massive balloon, and they cannot bear any weight on their foot. Zero weight, will not walk, so they don't even bother seeing you. They need to go get immediate attention, and they know it because it's very severe. They go to the emergency room. But for nurse practitioner purposes, grade 2 will be the one that will most likely show at your office. And who is this? This is the patient who twists their ankle or whatever, and is swollen all right, and it's painful all right, and you see that it's partial tear, not full tear like on grade 3, but they can still bear weight. It's painful, it hurts them, but not enough to go to the emergency room. They can still bear some weight. So what do you do for them? Well, there's not much you can do for them other than tell them to go home and rise. Rest, ice, compression, and elevation. You tell them that it'll take 4 to 6 weeks to heal, rise, and sit as needed, but most importantly, early mobility. You want these people to move because movement causes blood flow to the area that brings fresh oxygen and nutrients that will feed the area so that it can heal, and it will take away all the waste products and dead cells, and everything will heal beautiful. But you don't get that if you're laying down in bed doing nothing. You need to move so the blood flow gets into the area. So tell them early mobility. Let's talk plantar fasciitis and other things. So where is the pain located? Right under the heel, like in between the toes in that area. And who suffers from this? Think of the really heavy individual who's got a lot of weight to put stress on the foot and pulling. And the other one would be the one that causes constant pounding into that area. So your Zumba instructor who keeps jumping, or your runner. These are people who keep stressing that area. It's going to cause pain, it's going to inflame, and you have plantar fasciitis. Now, when is the pain worse? if you think about it, with most pains, in the morning, it's when things are stiff. You haven't been moving because you've been sleeping, and there's not a lot of blood flow in the area, and the muscles are cold. So morning. In the morning, the pain is worse. Once you get moving, the blood starts flowing, the pain starts feeling a little bit better because things are warm. So morning, the pain is worse. Look at the asterisks in my PowerPoints. It's a hint of stuff that you should really know. And I'm not saying any more about it, but you should really know it. Now, what is the best treatment? Well, guess what? If it's Zumba or running, you tell them to take a chill pill for some time because they need to rest the area that's inflamed. If it's overweight, well, we'll tell them to lose weight. And you tell them to rise. You tell them, rest, ice, compression, elevation. And you tell them NSAIDs if needed because they're swelling. So they need to decrease the swelling and they will be fine. They can stretch it. They can roll it with a ball too. Let's talk McMurray's. Now, because I'm a foreigner, and you probably already picked it up because of my accent, I have a hard time remembering all these names. They all sound the same. They all start with the letter M. So this is how I remember it. McMurray's, you should think it's meniscus. McMurray's with an M is for meniscus with an M. Now, McMurray's ends with rays, like x-rays, and you take x-rays of bones like the knee. So when I see the word McMurray's, I think of the knee and I think of the end for meniscus for those reasons. I hope it helps. Lachman. Lachman, if you picture in your head what Lachman is, it's the pulling of the bottom of the leg, right? The patient has the bent knees and you're pulling. So what prevents the knee that you're pulling from completely coming out this way, it's your ACL, anterior for A, right? ACL. With your ACL, if I pull on the bottom, your knee, your tibia, let's say, right? It's not going to come this far from your femur or patella. But if your ACL is not holding things together, blah, it's going to come off. So the Lachman, you're checking for ACL or knee stability, right? I hope you don't forget. Finkelstein test. The Finkelstein test tests for, here goes me pronouncing anything's funny, de Quervain, all right? What is Finkelstein and what is de Quervain? This is people, it's another overuse, a lot of overuse from the thumbs, texting, video games, or whatever you do, knitters, whatever you do, a lot of this, causing a lot of stress in this area. You do the Finkelstein test where you put the thumb down, ask them to put the fingers over the thumb, and then you tell them to pull here, which hyperextends this area. And if it causes pain, then de Quervain. Just know that. Morton's neuroma. This is one that most people don't have a hard time remembering. Morton's neuroma with an asterisk, so know it. It's the one that happens on the foot. This is the patient that comes in and tells you that they have either pain on the third and fourth metatarsal of the foot, or they have numbness and tingling, but not necessarily pain of that area, or they feel like they're stepping on a stone or a pebble. Those three characteristics or descriptions of their symptoms should automatically make you think Morton's neuroma. How do you test it? You squeeze the foot, and if it causes pain, you should think Morton's neuroma. Let's talk about Tinel's and Fallon. You should already know we're talking about carpal tunnel syndrome. And what is carpal tunnel? It is stress on, you should know which nerve, median nerve. No, it's the median nerve that it's stress, inflamed, causing this discomfort. So you can do the Tinel test where you're tapping at the median nerve until the patient feels discomfort because you're aggravating the nerve, or you ask them to do the upside down prayer for like a minute. After about 30 seconds or so, they're going to tell you this is very uncomfortable and painful, and this is Fallon. Both checking for the same thing. How are we doing with time? 11 minutes. I'm going to try to speed up a little bit. I want to get as much information in as possible. So how to recognize a stress fracture? The question will read something like, female athlete, she's been running, and now she's getting ready to compete at a, I don't know, marathon, triathlon, whatever. And through her training, because she's increased the amount of running, she's developed this pain on the front of her leg, right by the tibia area. And you should automatically know that it's a stress fracture, also known as shin splints. And what do you tell the patient who comes to you complaining about this because she needs to do her marathon? Well, you tell her, well, lady, if you keep exercising this at this rate, you're going to continue to cause stress and it's going to get worse. You recommend them to take 4 to 6 weeks off, rest the area, don't run too much, and they probably won't listen and they'll do it anyway. And you can recommend them rice, some NSAIDs, rest, but keep moving. Now, how do you differentiate between a sprain versus a strain? And I'll tell you my secret. My way of remembering a strain is that strain has the word train, and a train has muscle power because it's so fast. It's muscle power for the train. So a strain, it's a muscle. And sprain is spring and it's soft, so it's not strain. So if you see strain, you think muscle. Cauda equina syndrome. These are the people, and it's an emergency. There's nothing you can do for them. But if you see this, you send them immediately to the emergency room. This is the patient, which the question will say, comes in or complains of saddle numbness, or all of the sudden out of nowhere, incontinence of stools or urine or both, and you don't feel things down there. Just remember where cauda equina is located in the spine when you took anatomy and physiology, where the nerves are coming down the spine and they begin to divide and it looks like a tail of a horse, which is where the word comes from. It's like the tail of a horse. It's all these nerves branching down onto the legs. So if something happens right there where all those nerves branch off, there's going to be numbness and not good things happening down there, like loose stools, incontinence of all this stuff. Emergency, send them to the ED. Nothing you can do for them. Let's talk Osgood-Schlatter disease. Osgood-Schlatter disease, it's the young, growing patient who has pain on one or both knees. I did get to see it on my pediatric rotation for NP. And I saw this patient who on both knees, they have these like epicondyle protrusions on the knees, like literally bony protrusions on the knees. Sorry, kid, you're growing. It's going to hurt. It's going to go away. Rice. All right, rice. Maybe something for pain, but no emergency. So deal with it, kid. Polymyalgia rheumatica. Polymyalgia rheumatica. So rheumatica, think of like, I think of, inflammation, swelling of the joints. Poly meaning a lot of areas. This is typically the female that comes in and it hurts them here, 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 here. It is a long, chronic kind of pain and discomfort. It's not like 2 to 3 days and they're fine. So when you think about treatment and medications, because it's chronic, you're not going to give them NSAIDs. And as much as you don't want to give chronic use of steroids, for polymyalgia rheumatica, you need to calm down the joints because they're inflamed and swollen and angry. And the best way to do that is through steroids. So you give the patient steroids. Apley's grinding test. I hope you know this one. Also, it's when, think of it grinding. Literally, the patient is laying down on their belly with the knees bent so that the bottom of the foot is facing to the ceiling, and you grab your foot and you're grinding down the meniscus. You're grinding down that meniscus, and if it causes pain, it's because there's probably degeneration of the meniscus, and that's Apley's. We talked about McMurray's. You should master it. Anterior drawer test you should be familiar with, and Lachman we did mention. So let me just move a little quick because I don't want to go over 30 minutes because I don't want to bore you. But we have to talk about derm, a lot of derm. I put mountain spotted fever together with Lyme disease because you treat them the same way. And I hope you know that it's with doxy. Lyme disease and mountain spotted fever, it's doxy. Now they're both caused from the same thing, which is a tick bite. The patient that is hiking and comes back, let's say it's really bad case where the palms of the hands and the soles of the feet have sloughing of the skin and it's red, mountain spotted fever, give them doxy. Lyme disease, you should be familiar with the bull's eye and East Coast, right? Same patient, gardening, hiking, tick, okay? Shingles immunization, I go over it in more details in a different slide, so I'm going to skip it for now. You must master the difference between a macule versus a papule. And I hope you know that a macule is flat and that the papule pops from the skin. It pops out of the skin. So a freckle would be a macule, and anything that pops, like a wart or something, would be considered a papule because it pops like a pea papule. I got you. Impetigo. Impetigo with an M. Impetigo, the letter tells you it's treatment. Impetigo for mupirocin. M for impetigo. No, I wish it was the first letter, but it's not. Impetigo mupirocin. And if the question reads anything about honey crusted lesions, there's nothing else that looks like it. It is impetigo, highly contagious mupirocin. That's all you need to know about that. Now, purulent versus non-purulent cellulitis. Purulent cellulitis is gross. It's probably MRSA. MRSA causes purulence. And if you're thinking MRSA, you should be thinking antibiotics, B, C, D. MRSA, B, C, D. Bactrim, Clinda, Doxy. That's it. That's all you need to know about that. But if the furuncle or whatever abscess is non-purulent, Keflex. Make sure you remember that. Keflex is your drug of choice. Now, let's talk about what prodrome means, because I saw it on a question. I thought it was very clever. And if you've never seen this word or you don't know what it means, you're going to completely not understand the question. So here, I'm going to teach it to you and you'll never forget. So if the question reads about a patient who has known herpes labialis, the question wants to know what are the prodrome symptoms of herpes labialis. Prodrome means before the eruption happens of the vesicle on the labia or the lips. So if the answer reads anything that it says numbness, tingling, and burning sensation in the area where the vesicle will come out, that's your answer. Prodrome means the symptoms that the patient feels before the eruption of the herpes lesion. So don't forget. Let me talk about tinea corporis. If you know a little bit of Latin or if you speak Spanish, you know that corporis comes from the word body, cuerpo. So this is your ringworm. And no, it's no worm. There's no worm involved, which sucks that they even call it a ringworm. It's actually caused by a fungus. So if it asks you for treatment, you're going to go for the azoles, right? Any antifungal will be the right choice for this test. For this test, there are specific drugs that you must know, which I do talk in my presentation here. But majority of the questions will ask you for just a general group of classes. So I'll point out the drugs that you must know because there's a few and you need to master those. Lupus test. What is the diagnostic test for lupus? ANA. Asterisk. Next. Molluscum contagiosum. This is when they present with these round lesions that have like a belly button center. Highly contagious. It goes away on its own. Sometimes it could be caused by anything. But the one thing you should be alert is that if a pediatric patient comes in with these growths on the private parts, no good. Something really bad. I can see some sexual abuse of some kind. You better report that right away. And Herald's patch. When you see the word Herald's patch, when you see Christmas-like pattern, when you see, if they say, pityriasis rosacea, all three mean the same condition. Pityriasis rosacea, Herald's patch, Christmas tree-like pattern, we're talking about the same thing. That's all you need to know. And let me check my timer. I have 1 minute and 45 seconds. So let me pause my timer because I already know I'm going to go over. And this is the last slide I'm going to talk about in this recording. I have so much more information to show you. I hope this is a good way of learning the material. This is what I used to learn everything. But just know that I'm going to go through the slides quickly to show you what other content I have on my presentation. And just know that at the very end, I like to spend a good 30 minutes plus of just questions, throwing questions that are not covered in the PowerPoint presentation, but it's stuff that you should know automatically. But let me finish with this slide. Let's talk about the skin. And let's start with the top left-hand corner. If the question on the exam reads, there's a round, waxy, pearly, it may have a center that bleeds easily. This one particularly doesn't. You can see that it's got vascularization. You can see some vessels underneath. What are you thinking about? I hope it's basal cell carcinoma. And you should also know for testing purposes that from all the cancers, the most popular between women and guys put together, it's basal cell carcinoma. It is the most common cancer of both sexes. So know that. Let's move to the right. And these are, they look like warts or things that have been literally just like put on the patient's skin. They're not, and they usually grow because of older age. They could be cosmetically removed if they don't like it, but they're harmless. But you know, they're kind of ugly. It's just like sitting on the skin. What are these? And I hope you're thinking seborrheic keratoses. That's all you need to know. Let's move to the right. And this is a biggie. I hope you know by now that it's melanoma. And how do you recognize melanoma? A, B, C, D, E. A for asymmetric, B for borders, C for colors because it's brown, tan, black, D for dimension or diameter, it's greater than 6, and E, I think this is elevation, or maybe it's just A, B, C, D. Anyways, those are the ones that you need to know. Very dangerous. They need to go to an oncologist right away. You can't help them. Let's move to the right, the elbow. Patient comes in and they have silvery plaques. That's, if you see those words, you automatically know that it's psoriasis. Silvery plaques, psoriasis. Next, let's go to the bottom left-hand corner. This happens on the, primarily on the folds. That's why it's on the back of the knees. You see that redness and you should be thinking eczema. Next, let's look at the picture on the center bottom. Now, let me tell you about this picture. Usually it's the guy or woman who loves the sun, and this can happen on sun-exposed areas like the cheeks, the nose, the lip, the ears. And it's the precursor to the picture on the right that has that ulceration that just doesn't heal. So let me go back to the center one, and I hope you're thinking actinic keratoses. This is the precursor to the picture on the right, which you should automatically know it's squamous cell. So that's the skin, you guys. I hope everything has been helpful so far. Let me briefly show you what else I include in my PowerPoint presentation on a separate video. If you're interested, let me know. Send me an email back that you're interested on the remaining of the PowerPoint, and I'll send it to you. Excuse me. We do talk about testing strategies. We do a bunch of questions, quick, you know, I throw at you and I pretend that you're answering me, but I'll give you the answer. Lots of questions that are not included in the PowerPoint that I think you would highly benefit from mastering. So let me just quickly show you that we go over these two conditions, which is lice and scabies. We talk about the treatments and how to recognize them. We talk about erysipelas and the treatment. We talk about burns. The test will ask you, a patient comes in and they had the front aspect of the left arm burned, with including the front of the chest and the belly and anterior aspect of both legs. What's the percentage? So you have to master finding out the percentage of burns, and I'll be more than happy to teach you how to do it, which I do on my other presentation. We talk about acne and its treatment. We talk about PVD and how to differentiate between arterial and venous in greater detail. We talk about testing. You need to tell patients to stop smoking, hint, hint, asterisk. We talk about urinary, we have problems like the difference between overflow, stress, and urgency, and who will most likely have which one and why, so you can recognize it. We talk about vaccines, and you do not have to know all of the vaccines. I'll tell you the ones that you don't have to know. I'll tell you the ones that you have to know, and I'll tell you what you have to know about the vaccines, which is not a lot, believe it or not. But what you do have to know, you have to master. We talk about the height of the fundus, because the test may ask you, at what fundal height should the fundus be at week 12? And you should know it's at the pubic bone. And you don't have to know the numbers, but you have to know 3 of them. And my presentation shows you. You have to know if it's presumptive, probable, positive sign of pregnancy. You must differentiate and be able to recognize placenta abruptio versus placenta previa, and I'll tell you how. We talk about all those other things in pregnancy. We talk about pediatrics, all these things mentioned on the slide. We talk about rubella, Kawasaki, chickenpox, and how to easily recognize one from the other, because they're very different, and I'll teach you how to recognize it. We have to talk about development. You don't have to know all the months and years, but you do have to know the ones that I mentioned here, and you can't forget. I do use this boxes here to differentiate between COPD and asthma, and I'll teach you how to read it. This I talk about and how to master it. We have to talk about giant cell arteritis. We have to talk about heart attack. We have to talk about STIs and their treatments. We have to know master gout. We have to know about the prostate medications, incontinence, what hypertensive medication. This is a specific one you have to get with people who have BPH. There's a specific drug that I've never seen given with any other thing, any other hypertensive medication, but one specific, and I'll tell you what it is. You must know your herbs, and I'll tell you how I memorized them. You have to know adolescents, gynecomastia, primary, secondary amenorrhea. What does it mean? When does it happen? What should you test for? We have to talk about headaches, and the test did trick me on this one, and I want to make sure you don't get tricked, so I teach you how not to get tricked. This is something you must master, and the way that I have it written down here, it's the easiest way to remember. Once you learn this way, you'll never forget for the test. You will not get your murmurs wrong if you learn this way, which is very easy. We talk about hypertension, who gets what, who should you avoid this hypertensive tube with. These are really important subjects that you must master, and I do it in a very easy way to remember. We have to talk about the eye, cotton wool versus silvering wire, and if you see any of these keywords, you have to know which one is what. Specific dates, who gets colonoscopy, what age. We talk about shingles, pneumococcal vaccine, how to differentiate between mono and strep. We talk about respiratory, a lot of respiratory, but here's the basics. The most important thing you should know about respiratory, such as pneumonia and tuberculosis, who gets it, what are the causative organisms, easy way to remember everything. We do go over anemias. We have to know about assessment signs. We have to master Tanner stage, which is so easy because there's no way you have to memorize everything. There's few specific things about each stage, and I'll tell you what it is that you need to know. And at the very end, we do speed questions where I quiz you, not on the stuff covered in my presentation, but just other stuff that it's out there that you should know for sure that I have not included in my lengthy PowerPoint. So if you think that the very beginning, the first 30 minutes were helpful and that you could benefit from the remaining of the video, send me an email, let me know, and then I'll forward you the link so that you can study the remaining. I hope this helps, and I wish you the best luck in studying. And if there's anything I can do to make your studying any easier, I want everybody to pass just like I did, because I know how meaningful it is. Take a deep breath, reach out to me if needed, and I hope this helped. Thank you, guys.